So the evaluation of what we do is very important, both in a research context and an academic context, having done a feasibility study in an RCT, but then also in looking at the national rollout data. So we've got data so far on almost 7,000 children, which shows results that are broadly in line with the RCT, which is very important, but it's all very well to do a nice controlled study, but when you actually move into real life, you've got to maintain those results. And 90% of the children reduce their BMI Z-score over the course of the program. I'm sure as public health professionals, you'll all have intimate knowledge of what an ISA is. I had absolutely no idea. It's an incremental cost effectiveness ratio and is a standard health economics term. I apologize for my previous ignorance, but what it basically means is that at an ISA of under £2,000, MEN programs are less than 10% of the NICE threshold for cost effectiveness, so highly cost effective. We thought it was very important to try and undertake this work with York Health Economics and NEF. And we can see that there's a pretty significant value per family. We also believe in trying to make local delivery easy. So it's very much about using local health professionals and other professionals to interact with their local population. They know the population, they know the facilities, they know the environment, and many of them know the local, local cultural groups and the most at-risk target groups. So we'll make the stuff that is common where you can get some real savings, we'll make that as easy as possible. So we supply full kit bags and everything else with the programs and manuals and training. There's lots of interesting, exciting stuff like logistics and account management, quality assurance in a range of different layers, and media and communication support. We have a bespoke web-based system that allows the secure storage of data and the measurements at the beginning and end of the program. It produces reports for the program managers, and we've done it so it can work for a whole range of different programs and a whole range of different metrics. We've actually just started to work with some other people to use the system to help support their programs, so very happy to talk about that further if required. And then using that data as benchmarking to actually improve performance, help learn from the poorer performing sites and the better ones and try and spread those lessons both ways. Moving into continuous improvement of the programs, so it's not just about having a program and seeing if it works and then saying, great, excellent, it's a lovely program. It's about making sure that we continue to bring in the feedback from the children, from the emerging research and from the leaders in the field. That allowed us to scale up to about 300 sites around the UK. And I've excluded the north of Scotland, despite being Scottish, because we don't have any programs there, not because I don't like Scotland. In fact, I go there on a regular basis. We only get, with all of those little red Google pins, we only get to 1% of the UK's overweight and obese population. And so it shows the enormous need for scaling up these kind of programs. We've had lots of partners help us do that, public and private, Welsh Assembly Government, Partner of Change for Life, etc. Many, many more local partners, both PCTs and local authorities, and I guess a few more local authorities coming soon. And a range of others. And we've reached a fairly large number of people to date, but as I say, a pinprick in the grand scheme of things. So in the interest of time, I will leave that there and move on and let Phil carry on and finish off.
Gosh. So, what needs to happen next in terms of a new direction for public health? These are the players that we think we need to alert. In terms of weight management, we're arguing for an approach that's championed nationally, enabled by experts and delivered locally. We feel that government has a large role to play in setting policy direction, and it's heartening that improving public health continues to be a key priority for the coalition. And Paul Burstow sat with us at a fringe event at the Lib Dem conference 2 weeks ago. Like you all, we're all eager to see the new public health white paper in the autumn, or is that going to be the winter or a long autumn? And we hope it takes a lead in addressing health inequalities and tackling obesity. Local government, in partnership with emerging GP consortia, are going to be key, aren't they? And they'll be at the heart of commissioning the delivery of suitable public health interventions. And if you stop for a moment to think of the collaboration that that partnership could bring, just imagine the effectiveness of a public health army that may consist of newly qualified health trainers from the fitness sector, the education sector. I've always had this dream about joining up PE, PSHE and student wellbeing, local sports and physical activity clubs, alongside more traditional players from the health sector. That must include a more prominent role for pharmacists in playing that role in prevention. Business and the third sector is going to be absolutely critical, and that's where we're going to see innovation. Men, for example, we're doing a pilot at the minute where we're working with the Dame Kelly Holmes Legacy Trust and using a world-class athlete up in Dudley to actually work with our families and wondering, can that whole process add value to the behaviour change that we're trying to bring about in the participating families? And finally, we believe that an emphasis must be placed on challenging individuals to take more personal responsibility for their own health. But we acknowledge we can't force that change in behaviours, but we know we're going to have that panel debate later on. We can certainly nudge people in the right direction to make those right choices. And finally, we've got a vision to recycle, how about this of being green, 15% of our graduates from our programmes to become local community health ambassadors and join that huge public health workforce. After completing a structured training programme, these volunteers will signpost local people to appropriate services and become ambassadors for healthy lifestyles within their own communities. You know, if lasting and meaningful changes to be made in really hard-to-reach communities, those that Marmot refers to, then who better to do it than change agents from within? So what we're really after is quality, value for money, continuous improvement with really high-quality local outcomes.